2008. I'm working in Congo with women traumatized by war. My first delivery. A young woman refused to push her baby out, and I did not know why. I asked the local midwives, and they told me her first child died while they were running from the Mai. Local doctors here cut women open with no anesthesia, and they die. She is scared. This story is shocking, but not uncommon with women traumatized by war. And I thought then, there is nothing that compares to this in my country. But I was wrong. It's 2014, I'm working in Maine. A woman who had just moved here was pregnant with her fourth child. Her first birth was normal, vaginal, everything was fine. Her second was breech, and she agreed to a C-section. Her third, she wanted a VBAC, a vaginal birth after cesarean, but was not allowed that option. So against her will, she had a repeat C-section and then suffered a severe postpartum depression. Pregnant again? She is scared. She is so scared, she's considering staying in a camper with her 3 kids to be near the only hospital that will support her decision in New Hampshire. And I thought, we traumatize women in my country too. We just put a cleaner face on it. When I tell audiences the first story, they often ask me, what can we do? When I tell them the second, silence. The horrors in Congo were so great, I was worried about coming back and working here. I was afraid I would have no compassion at all. Instead, I began to see some parallels, some universal unfairness for what happens to women in a healthcare system. When I left Congo, I promised the women I would tell their story. I felt it was the only lasting good I could do, to raise awareness of what happens to women affected by war. And I've done that. I wrote about it, and I speak about it. And now I feel I have to tell the story of women right here. In the United States, the maternal mortality rate is rising. We are one of 8 countries where this is so. Here, it has tripled since 1980. Why? Poverty, lack of access to prenatal care, and disappearing services in rural areas. Native and African American women die at triple the rate of white women. When I spoke to an audience of midwives 2 years ago, someone asked me what was my biggest frustration with our healthcare system. And I told them I have many, but I used the example of VBAC. This practice, once commonplace, has been banned in many hospitals. And many, many women are forced to have repeat C-sections they do not need. We watch as women are wheeled into the operating room, often against her wishes, forced by our system to have major surgery, which puts her and her baby at increased risk. I told this audience I would no longer call this unnecessary surgery. I will start calling it what it really is, mutilation. We are mutilating women for profit and convenience. I said, none of us agree with this practice, but we watch it happen. Yet, if we saw someone coming at a woman on the street with a knife, we would call 911. We can argue with those in power, we advocate at policy meetings, we cite all the data, and still, she gets wheeled into a room where her life is at risk for money. And the last time I watched this, I thought, if she dies, this will be manslaughter. She was emotionally manipulated into agreeing to this surgery. Nobody wants their baby to die. No woman goes into childbirth wanting to die. So, when a person in power says to her, if you attempt a vaginal birth, your baby could die, of course she says yes. The World Health Organization estimates that between 6 and 15% of C-sections are necessary, and the rate in this country is now 34%. And women are dying from complications from those surgeries. I am calling 911. After 23 years, I quit a job I loved. I agonized for a long time making that decision. I had a comfortable life. I was working in the women's center I helped create with women I loved. I loved my patients, I loved my community, I had it all. But over the last decade, I have watched as improvements made in women's health started disappearing for profit. Outraged, I spoke out at meetings, I lobbied in Washington, I yelled in the hallways. I realized I was working in a system whose values I no longer shared, and I was angry. Poor women do not have the luxury of expressing anger in a system that abuses them. They are labeled and judged and unwelcomed. So as difficult as it made me to work with, I felt it was my job to do it for them. When I was a public health nurse in Peace Corps, our goal was to have a maternity clinic situated so that no woman would have to walk more than 5 miles in labor, and this would take her about an hour and a half. Now consider a rural woman who traveled to Bar Harbor for her pregnancy. She was poor, though she and her husband both worked full-time in physically difficult, low-paying jobs. They had unreliable transportation. The hospital closest to her refused to care for her baby, so she traveled almost 2 hours to get to this hospital where she hoped to have a vaginal birth. She had had a previous C-section for breech, but her chances of delivering vaginally were excellent. I advocated and fought for her safety and right to a vaginal birth, but under pressure, she agreed to a repeat C-section. That then put her at increased risk for blood clots, infection, chronic pain, and death. But it was convenient and profitable. Surgical birth carries a higher risk than vaginal birth for mothers and babies, long-term risks. Surgical complications are a factor in the rising maternal mortality rate in this country. A woman has a 3 times greater chance of dying if that birth is by cesarean. Yet, this statistic rarely, if ever, gets included in the information we call informed consent. When the natural birth movement took hold in the 1980s, hospitals got on the bandwagon because there was competition for deliveries, since women are loyal to the place they deliver and they make most of the healthcare decisions for the family. So this made economic sense. But when insurance reimbursement changed, maternity care became more costly for hospitals with low volume, and many in rural areas eliminated those services altogether. And now poor and disadvantaged women must travel sometimes over 2 hours to get to a facility where they can deliver safely. They have no money for gas. They have no one to care for their other children. They go without prenatal care. They have so much anxiety about getting to the hospital in time. They are being scheduled for induction of labor or a C-section, and their risk of dying then triples. Maternity care may be expensive to provide, but every single study out there demonstrates that natural birth at full term results in healthiest mothers and babies, and this means having services available. And yes, this costs money. Cardiac arrest costs money too, but we don't eliminate those services. What I want to know is, why aren't hospitals asking what we can do to provide this service in a way we can afford? There are solutions out there. It is estimated by the World Health Organization that if we increase the number of midwives in the world by 25%, we will reduce maternal mortality by 50%. This is not a rare disease. This is pregnancy, a normal condition 80% of women will experience in her lifetime. It does not matter that numbers are low in rural areas. All women deserve a safe and respectful way of giving birth. It is a basic human right. So I hope you're all now asking, what can we do? You can call 911. It's time. Reach out. There is a sister nearby who needs you. Start a support group. Take time to meet and brainstorm about how we can help each other. We are better off when the poorest among us are better off. Drive someone to her appointment. Start a childcare co-op. Be a mentor. Demand to have women's health services available in your community, including a midwife. Driving 2 or more hours in labor is torture. And to my colleagues in healthcare, make this a priority. Combined, our voices will be harder to ignore. Thank you.